start this. All right, guys, thanks so much. Sorry about the delay, but it is, obviously we're heavily reliant on technology these days, and as a result, sometimes there are a couple of hiccups along the way. So I just wanted to do a quick just run through of the agenda. Firstly, to say thanks so much to everyone for joining, as well as our speakers. I think that this is the first MG sort of online connection that I'm aware of, and I'm really excited to have been able to bring the community together during MG Awareness Month, and I hope that everybody gets some value out of today. I'm sure excited myself to learn. So we're going to have three presentations, the first being by Prof. Hickman, the second being by Candice Mess, who's an occupational therapist, but I'm sure you all know is also an MG patient. And then last but not least is going to be Barry Shingwenyana, who is a genetic counseling intern. So let me, obviously, if you are, only the panelists have video today. If you're wanting to answer any questions, please do so using the Q&A functionality. So there's a Q&A, if you look at the bottom of your screen, there's a Q&A option there, and if you click on that, you'll be able to then answer during the Q&A. So using the chat functionality, you can chat to everyone. So if you want to say hi to everyone that's on the call, you can click to chat to everyone. Alternatively, you can bring something to the panelists' attention if you feel that that's necessary. So Nicola and myself will be assisting from a administrative perspective. And if anything is required, please just pop it to us in the chat. Eileen, I see you have raised your hands. If you wouldn't mind, please just popping your query through to us in a chat or via the Q&A so that we can address it directly. So I'm going to introduce Prof. Very excited. Thanks so much, Prof. I know that things must be hectic at the moment with everything that's happening with COVID. Prof. Hickman, neurology at the University of Cape Town at the UCT Neuroscience Institute, and her questions related to neuromuscular diseases within the African context, with a particular focus on MG, ALS, and inherited neuromuscular diseases. And the title of her talk today is What is Happening in the Medical Space with MG? So, Prof, without further ado, I hand over to you.
Okay, good morning. Thank you. Can you hear me? Yes, okay.
Yes, you can.
So thank you very much. And so, yeah, you've given me 15 minutes. I've prepared 17 slides. I'm going to go through them slowly. And if time runs out, then please just let me know and we can stop and we can go back to it. I've got my earphones in and can I try and do this? How's that sound? Is that better or not? Is that okay? All right.
No,
so that's better.
Fine. We can hear you.
That's better for me, actually. Yes. Okay. So, of course, I tried to just find from the literature a few things that I thought would be interesting for people to know. But I think the first thing is just to get onto the same page with respect so that we can talk about a few approaches to treatment. And then I'm going to just touch on a few things that I think are relevant to in the South African context. We will talk about thymectomy, rituximab, exercise, cognitive fatigue, and then finally just a few drugs that are relevant in pregnancy that often comes up. But the first thing is just to get onto the same page so that we all know that we're talking about the same thing. I'm not sure, yes. So we all know that myasthenia is it's an antibody-mediated disease, and there is, here's the neuromuscular junction. I don't know if you can see my pointer. And we are talking about this particular area, and as you know, when the muscle gets activated, the electrical stimulus comes down the nerve, activates these chemicals to be released, so that the electrical stimulus, gets converted into a chemical stimulus, which gets onto the receptors. Where's my thing? Receptors on the end plate, which is almost like satellite dishes, accepting the chemical stimuli, and then the muscle is contracts. So in most cases with MG, there's these antibodies that attack the receptor or satellite dish, and the consequence is that they can either be blocked, but that is very, very infrequent. Most of the time, these antibodies, in fact, damage the receptors and even downregulate the receptors, so the receptors are lost. And you can see the top picture here. This is a normal neuromuscular end plate where there's lots of folds, etc., at the muscle junction. And in myasthenia, where there has been a lot of damage, the folds are reduced and the whole end plate is actually dysfunctional. So, so the thing is that our approach to treatment is then also to have symptomatic treatment, which is Mestinon, and that really acts here at the signal. So it just boosts the signal. And I always tell my patients that they are in charge of the Mestinon because it's a symptomatic treatment. If there aren't any receptors or satellite dishes, of course you can boost the signal until it comes out of your ears. Nothing's going to happen, because you do need the receptors. And that's where the immune-mediated disease comes in, because it's actually getting to the root of the problem by reducing the antibody production, which is causing all the damage, and allowing these receptors to resprout. Every 5 days, we make new receptors. So if you can reduce the antibody attack, you can try and recover your receptors at the end plate. So having said all of that, what about thymectomy? So this is, we know that that many cases with young onset and antibody positive myasthenia have got large thymuses, and that's a gland just behind the breastplate, behind the sternum, and this has been a long question that was that's originated already in the 1940s, when the first case with a large thymoma was actually operated on and the thymus was taken out. And that particular patient actually got better. The subsequent 2 cases of that surgeon didn't do well, but the question was what is actually, does thymectomy work? At the same time, corticosteroids, or ACTH, which is the sort of precursor of steroids, was also discovered. So steroids and thymectomy was almost started with full myasthenia at the same time. So it was never really answered, does thymectomy, is it worth doing? It's a major operation. You do open the chest breastplate, and does it really work? So there was an international trial that was performed, and we were actually in Cape Town. We were the only African site that participated in this trial. And the first results came out in 2016, and there was another paper in 2019, and we've got another one in press at the moment. But the question was, does the thymectomy actually make a difference? So 60 patients were randomized. They couldn't decide whether they wanted to have a thymectomy or not. If they were in the study, they had to be randomized. So either 60 patients received the thymectomy and steroids for a year, and 60 patients received only prednisone, the steroids, for a year. And this is the results. You can see here. After a year, we could use other medications. But in the third, and of course, as I said, Mestinon, the symptomatic treatment, could continue. There was a maximum ceiling dose that was used, but that could continue. And then the patients were also assessed by a blinded observer. So this was a doctor or a neurologist who did not know whether the patients had undergone surgery or not. And you can see here that very, very quickly, within 6 months, there was actually both improved. Of course, they were on steroids as well. But there was clearly a shift between these 2 groups, the thymectomy and the prednisone. And that shift continued until 3 years and even 5 years. And the dose here on the right-hand side is the prednisone dosing, and the doses of the prednisone were also significantly different. And that really was the beauty and the main result of this trial, that after 5 years you could use lower doses of prednisone. I mean, for 5 years there was this persistent effect of lower doses of prednisone. So the patients that were included in this trial were only patients that had acetylcholine receptor antibody positive myasthenics. They were between 18 and 65 years, and they had symptoms only for less than 5 years. So that really is the result pertains to that particular group. And what it has meant is that we now know that the thymectomy does help for patients, particularly in my view, the patients that are very reliant on ongoing steroids. That's when I really go for a thymectomy. I know that some centers in the world, as soon as they know that the patient has got antibody positive, generalized MG, they would immediately go for thymectomy. I don't do that because I feel that some patients, in fact, do very well without a thymectomy, and you can get them off steroids and mestinon within few months. And for me, then a major operation is not really indicated. But if the patient is resistant, they can't get better without using high doses of prednisone, then that is the kind of patient that I would then go in to do a thymectomy. And you've got a couple of years to work with. It's not an emergency procedure. There are indications for thymectomy that you would really always do, almost always, and that is thymoma. About 10% of myasthenics have it's a tumor of the thymus. So this is different to just a hyperplastic thymus that's full of plasma cells and making antibodies. These are actually a tumor. Most of these tumors are benign, so they just go enlarge in the chest, and that's why you want to take them out, because they just take up space. But a small percentage of them have become a cancer and become invasive, but that's a very, very small percentage. I've had patients with thymoma that are very old. When I say very old, I mean really old, like 95, that have said, leave my thymoma alone. Well, that particular patient that I'm thinking of had a thymoma diagnosed when she was 85, and she died at 95, completely well, still doing archery. And so it is, you can live with your thymoma, but in a young patient, we want to take it out because it takes up space. There has been a recent open label trial of patients that have MuSK-MG. And in fact, in that, it wasn't open label, so it wasn't blinded, it wasn't randomized, but they did have controls, and they found that the patients with MuSK-MG that had thymectomy actually did worse than those without the thymectomy. So even though it's not a definitive answer, we feel that patients with MuSK-MG shouldn't have a thymectomy. Some people feel that ocular MG, we don't do it for ocular MG, there's no evidence for that. And there is very little evidence for seronegative MG. Under exceptional circumstances, one would do that. And then that brings me to another particular kind of patient that will not have antibodies, and that will have a very long disease course, symptoms, often from childhood. It doesn't get worse, really. It's not a fluctuating illness. And that is what we call congenital myasthenic syndromes. They are rare, but they are due to inherited variations in the proteins around the end plate. And this is, as I say, this is an inherited syndrome that often needs mestinon, sometimes albuterol, but they don't need immune treatments. So this is a review that was done by a neuromuscular neurologist. And I just brought that up just to remind me to tell you about what has been happening in the space in the last decade. You can see in the 2000s, MMF, mycophenolate, and I'm not really going to talk about MMF, but I'm happy to answer questions. That was sort of came onto the scene in 2000, and rituximab as well. I'll talk a little bit more about rituximab. And then eculizumab is a drug that has been now got licensed in the US, and there's been a lot of trials. We haven't been involved with the trials. It is an extremely expensive drug, a drug that even the Americans roll their eyes when they talk about the expense of this drug. So I'm not sure that this drug is going to come to South Africa. It does seem to have a very good profile, but I'm not going to talk more about that. So what about rituximab or MabThera? So this is a drug that is a monoclonal antibody. So this is that's why it's so expensive. It's an antibody against a protein on the B cells called the CD20 surface antigen. And I've shown you here just how B cells develop in the bone marrow. And the CD20 protein is only expressed later in the B cell. Here, the B cell then eventually forms a plasma cell where there's no CD20 protein, but the plasma cell then makes the antibodies that causes the myasthenia. So you can see that there's the MabThera or rituximab is going to be quite effective against the B cell that actually expresses the CD20, and that causes the B cell to actually involute and destroy, almost auto-destruct, so that you then get a patient that doesn't have any, you deplete the B cells, and you therefore have got less antibody production. So this is a patient of mine with refractory MuSK-MG who I used rituximab in eventually. You can see here she came in with very severe myasthenia. In ICU, she had plasma exchange, she couldn't eat, we had to put a peg in for her. In fact, she had IVIG actually. We put a peg in for her, got a bit better, then she deteriorated again, had to have a trachea because she couldn't breathe properly because of paralysis of her vocal cords, and she had plasma exchanges, and I think these crosses are where we gave her cyclophosphamide infusions. She was not in a good place, and we then decided to use rituximab according to what was then called the rheumatoid protocol. I will talk about that now. And you can see that she had 3 different cycles of rituximab, and she's done brilliantly. Her peg was removed after about 3 years. Her trachea is still in situ, but she can talk, and she's back at work, and she's done brilliantly well. And she was really very, very refractory. So that is one of the few success stories. I've also used rituximab in a patient with HIV MuSK-MG, and she also did very, very well. So it brings me to the exciting news about rituximab is that the dosing has evolved significantly over the last few years. So rituximab was originally discovered almost because it was obviously causes B cell depletion. So it was used in B cell cancers, and that was called the lymphoma protocol. And the story goes that the one patient had a lymphoma as well as myasthenia, and the myasthenia got so much better, so that that is why they thought, well, let's try it in myasthenia. So you can see the protocol was quite hectic because it was obviously for a cancer. It was every week, weekly times 4, then 2 weekly, and then every 2 to 3 months. Then it was decided, okay, well, let's use it against a T cell disease because the T cells also have CD20, and it was then downscaled to the rheumatoid protocol, and that was 4 infusions weekly, and then 2 for 2 weekly, and then 6 monthly. And we use that dose as well. So most myasthenic doctors use that. In fact, a trial was done that was funded by the NIH, and using that sort of rheumatological protocol for myasthenic patients, and the results are about to come out. But I have also used this, and that was because of a paper by the Chinese where they suggested low dose rituximab, and for that they use 1 dose only, and that has had amazing results. I've had patients with MuSK-MG that has actually had only 1 dose, and the one patient I've been following now for 3 years, and she hasn't had another dose. She hasn't needed another dose. She's absolutely perfect. And there are people that are looking at ultra low dose, so that is 1/3 of the original dose. Well, why is that important? And that is because rituximab can have serious adverse events. You can have infections. It's not really, this appear to be something that we don't understand. Certain people are just very, very susceptible to it. It's not really related to whether there's immunoglobulin levels beforehand, etc. So we don't have a good biomarker to decide who is going to not do well or who is going to have problems. except the MuSK antibodies. The MuSK MGs appear to do at least twice as, they are particularly susceptible or to fantastic responses to rituximab. This is the study by the group in China where they gave one dose of rituximab, and you can see here the cells are depleted and they remain depleted. This is the level here of where we would be considering giving a repeat dose, and you can see here at 6 months all 8 patients still have very, very low CD19 cells. Here they measure CD19. The CD20, CD19 have sort of, they're very similar to each other. So some patients, the bottom line is that some patients can get away with one dose of rituximab, which really brings down the cost as well and makes it a very affordable drug. So rituximab is much more effective than MuSK MG. In fact, this is called minimal manifestation. So that is when a patient really gets into a position where they have no clinical manifestations of MG. They don't need mestinon anymore. And that occurred in almost 40% of MuSK patients after rituximab infusions. With the acetylcholine receptor antibody positive patients, that are obviously the most of the myasthenics, it was much, much lower. Only 20% of them went into remission on rituximab. So enough of rituximab. I thought this was an interesting thing to talk about. I'm not looking at my time, Kelly. You're going to have to wave and tell me I must keep quiet. But this is about, this is something, okay, so this is something that a lot of people have been talking about for several years now, and a lot of scientific papers actually on exercise and MG. And it's also in other neuromuscular diseases. There was a fantastic paper about 4 years ago on facioscapulohumeral dystrophy, which is a dystrophy that is associated with a lot of pain. And the Dutch did a study and showed that exercise actually reduces the myalgia, the muscle pain, and improves quality of life in FSHD. So the myasthenia literature has also been looking at that. And I was just recently listening to a talk by an Indian group, and what they did was they did a randomized trial of patients that were either mild to moderate MG, and they asked them to do an exercise regimen. They had to walk for 30 minutes every day for 3 months, and they gave them smartphones, so they checked that they were doing that. And they randomized them to the other group, were asked to do 30 minutes of just rest daily, and listening to exercise or reading. And then they looked at what the quality of life scores were after 3 months. And they found that those that were in the exercise group felt more than, there was a much more greater percentage of the exercise group that felt more than 50% better, even though the objective scores were similar. So the grading of the muscle fatigue was similar. They felt better, and there was no adverse events. And that has been a recurring theme across several studies. So it brings us to the question of cognitive fatigue, and that's also been there's been a lot of work on that, but that there's more to myasthenia than just muscle fatigue. So this is a paper that I looked at that had quite a nice study design. It was from Norway and published in 2013, and they had 87 patients of their MG patients versus 410 Norwegians that did not have myasthenia, but that were age and sex matched controls. And they did various scorings on these particular patients or participants. And they found that 40% of the MG patients had felt cognitive fatigue, symptoms of cognitive fatigue, such as lack of energy, poor concentration, autonomic symptoms. They had higher scores, and it was more frequent in the MG compared to the control participants without MG. So, and the major thing was sleep disturbance. I mean, there was a sleep disturbance in about 60% of patients with stable MG, And this is also being found in cohorts in the UK. So this is really something we need to think about and to manage. So management strategies, I would think, for this kind of thing is to recognize that MG patients have to deal constantly with a changing landscape, a physical ability landscape. You don't know whether how you're going to be feeling at 4 o'clock in the afternoon, even though you might feel fine in the morning. And I think that's challenging for patients and also for patients to manage the people around them, because I think that, you know, other people don't understand often that you might feel that you can, you know, clean the house in the morning, but come the afternoon, not so much anymore. And then attending to the emotional needs. I think that is very important. And as that one study showed, sleep is an important thing to reduce anxiety. It is important for us as human beings, for our computers, that is our brain, to reboot with a proper sleep. Exercise, as I've said, is important if you can. Obviously, if you've got very severe MG, then it's going to be difficult. And then to revisit drugs, because drugs, you know, to use the lowest doses that are necessary. And that certain drugs can also make things worse. Statins, for example, a lot of new MG patients, about 2/3 of patients that with newly diagnosed MG are older than 50. And so they are going to use cholesterol and other medications. So it's always good to go through your medication list and make sure that, that everything is required. I'm not suggesting that all older people must stop their statins, but I think that if you're a new onset patient with new symptoms of MG, just try and have a look at whether any recent drugs were introduced and could be linked to the manifestation of MG. And then in my clinic, I have a very close relationship with a fantastic psychiatrist who actually did her master's on patients with MG. And so she does cognitive behavioral therapy with patients, just to get to this and not all the patients, but patients that are struggling with cognitive fatigue and getting amazing results. So I think it is just looking at the patient as a whole. It's not just a physical disease. There are things happening around this particular person with MG. There's other drugs involved, and the stresses and strains of life in general. And so to be holistic in your management of the patient. And then finally, I think this is my last slide. I just wanted to make a point about drugs and pregnancy and lactation, that certain drugs are safe. I know I see a number of patients that have told me that they didn't start treatment earlier because they wanted to have their babies. If your myasthenia is severe enough to warrant immune treatment, then as long as the treatment is safe, as azathioprine and cyclosporin are safe, many pregnancies have happened on these drugs, because a lot of younger women have autoimmune diseases, and they are also the population that have children. So those are safe. Lactation is safe. You can breastfeed. The ones that to avoid are the M's, the methotrexates and the MMFs. Those are not to be used in patients who are potentially childbearing. I have 1 or 2 patients who are on methotrexate and or MMF that are young women, but those are because they've defeated all the other drugs and they know that they have to use contraception. And if they want to have a child, then we've got to get off that, wash it out for 3 months, cover them with prednisone or with another means, more costly means such as IVIG, have the child and then go back onto the drugs that are potentially teratogenic. And I think that's it for me. Sorry that I went over. I hope you found that interesting.
No, we absolutely did. Prof, please don't stress about having gone over. I think everyone was hanging on every word that you said. There have been quite a few questions that have come through. So I'm going to start with them if you don't mind. The first question was, how much research is done to enhance myasthenia? Are clinical trials held from time to time, particularly in South Africa? And how long does it generally take for medication to work optimally?
Yeah, so those are both very good questions. I think the first thing to maybe just the medications, and then I'll talk about the trials. My pen doesn't work, so you're going to have to remind me if I forget all the questions. So the one important thing about myasthenia is that you have to be patient. And I'm sure that some of my chronic patients are sort of rolling their eyes at me, but because they know this refrain. But one has to, it's not a quick fix disease. The medications take a long time to work, particularly the sort of entry-level medications that we use, such as the prednisones, take days to weeks, then steroid-sparing treatment, the azathioprines, methotrexates, the MMFs, they take months. Several months. The higher end drugs such as cyclosporin and rituximab will be quicker. So that will still be 3 months, 2 to 3 months to work. So it is not a quick fix. You can't take something now. If you know, the IVIGs and the plasma exchanges, in my view, are rescue treatments. They're not maintenance treatments. And they will be quicker. Cyclophosphamide is an induction treatment. We use that, and that works within a few days, but that's not a long-term maintenance treatment either. So to come to trials, yes, we are involved with trials, very few. I would like to have more, but it comes down to costs. You know, the drug company has to, or whoever's doing the sponsoring the trial, has to feel that it is worthwhile to bring a trial to South Africa. So far we've only been involved in 2 trials actually for myasthenia. But yes, I think that, you know, you guys can also agitate and bring these trials closer to home. We are certainly in a position to participate. Of course, they would like to have as many patients as possible to be eligible so that it becomes a cost-effective exercise for them. But yes, that is something that we should agitate a bit more for. But certainly I'm trying my best to be present and to get those performed here as well.
Yeah, very difficult. I think patients often underestimate the intense criteria and settings that are required for clinical trials. Right, the next question is obviously a burning question on everyone's minds at the moment. With regards to COVID, if you contract COVID, what would be the best way forward? Self-isolation, or would you suggest obviously immediately looking at extensive medical treatment, etc.?
Yeah, so I've had so far only 2 patients. I think the third one is sort of waiting for her COVID result. The one was both of them were stable actually prior, I have to say. The one had mild symptoms, came into hospital for a day or 2, needed a bit of oxygen by mask, went home, and absolutely everything was fine. Both of them, we continued with their medications, so I wouldn't change any medications. The other one had mild symptoms, went to her GP, had a bit of shortness of breath for a day or 2, felt that she was fine, didn't even go to hospital. And after that, she was perfect. She also didn't need anything else. She was just on her maintenance azathioprine. The first patient was also on very low doses of prednisone and just continued everything as before. There have been very few patients in the literature. I know there's one patient from Delhi that they, an Indian patient that they reported, who had quite advanced COVID, and that they, in fact, it was actually not an Indian patient. I forget, I've got it wrong. It was a patient in the US. The first author's name was Debbie, that's right. And the reason that I remembered that is because they actually gave the patient chloroquine, which of course is a quinine and will make myasthenia worse. But that was the sort of flavor of the month because of Donald. And And so that patient needed plasma exchange, but she really had a very, very bad chest X-ray from COVID, and managed to get over it with additional help. So I think the bottom line is that continue your treatment, isolate. If you are if you've got access to, I think it's a good idea to have the flu vaccine anyway. And otherwise just continue with your meds. I'm not giving any rituximab treatment, because I think that will give, unless it's, I haven't been in the position where it's absolutely necessary, but I would really, you know, I wouldn't use those kinds of biologicals at this point, unless it's absolutely, absolutely necessary. And then maybe just a shout out that we are participating with an international database run by a Dr. Pedro, who are now, just his surname has escaped me, but he's at University College London, and he's collecting data on neuromuscular diseases, so across the board, of patients that have contracted COVID and how it was managed, so that we can all learn from one another. So if anybody in your audience has had COVID, then they are very welcome to let me know, and I can contact the doctor and tell them how to upload their details. It's all decoded and de-identified, and it's basically just a new trend of doctors really helping one another and assisting, and sort of a more global fight against disease and how to manage it, so that we're not all in our little spaces and trying our own thing. We're actually learning from one another.
Yeah, absolutely. Prof, just a quick question with regards to the rituximab. Availability in the state hospital. You know, obviously medical aids are, the MG as a PMB only really allows for acute exacerbations and implementation of treatment. So we have seen that a lot of patients are declined for high-priced drugs unless they have what's called an insured benefit, meaning that they're on one of the top plans, you know, extensively comprehensive plan. From a state perspective and a state facility perspective, is rituximab easily, you know, is it easy to get patients on?
So I think that, you know, it's not easy, but we have it available if it is necessary. So we, you know, so this is not my first go-to drug. Even in MuSK-MG, it's not my first go-to drug. But if the patient has gone through a reasonable time period of the standard drugs, and we are not winning, or obviously if it is severely refractory and immediately very, you know, and we could see that there's going to be a problem, then yes, by all means we are able to use it. And we are now also, as I said, much more experienced with it. So we're using a very, very low dose. So we're using less than a quarter of what we used to use before. So it now becomes very cost effective and very attractive also for funders. That because it has got, especially in MuSK-MG, the problem is that we don't have cheap ways of diagnosing MuSK-MG in the country. So that is a challenge. But if a patient got severe disease, I think it certainly is worth a low dose one shot treatment to see if it helps. You know, previously we used to, and I think that's some of your patients that I had that are also part of your organization. We used high doses, and the sort of rationale was, well, you are so refractory. If we're going to use it, we might as well use the biggest dose, because if it doesn't help, then we know that we've done our best. But I think that has changed now, and that we know that a low dose is actually as good as the high dose. So you don't need to use the high dose. If you're not efficacious, if there's no response against the low dose, well, then you're just not one of those responders. So we have actually learned a lot in the last few years using this drug.
Very interesting, Prof. I know there are a couple of patients with burning issues that I is particularly on how to arrange a consult. So I will send details about the clinic and where they can get in touch. Thank you so much. Very, very, very interesting. Prof, will you be staying or are you going to be leaving us now?
No, I'll stay.
Okay, perfect. All right, so I'm going to stop sharing Prof's screen. Okay, so we're going to move on to our next speaker, and that is Candice. Candice is going to be chatting briefly about the disability assessments. It's also a burning question, particularly now. I think with a lot of people, are hesitant to go back to work full time, etc. Candice graduated from UCT as an occupational therapist in 2017, and she has completed her diploma in vocational rehabilitation. She has also worked in the field of mental health and vocational rehabilitation since 2009. Candice was diagnosed with generalized MG in 2007 and is able to provide us with a unique perspective on the assessment and therapy needs for clients with chronic conditions. Candice, so I'm going to hand over to you.
Thank you, Kelly. Yeah, strangely enough, I was actually a student in the neurology ward at UCT when I really started presenting with my symptoms. So right place, right time to be able to catch Prof as well. Okay, so functional assessments, what they really are is assessment to see exactly all of the spheres, all of what's happening in you and how you are reacting to the environment, to the stress, and your MG is influencing this. So it's normally performed by an occupational therapist specializing in vocational rehabilitation, and a lot of them would be on a referral basis from an institution like a Discovery that would be someone who would be have your insurance with you. Okay, so that what would normally happen is you would really come to a state where things are not working at your workplace. Either you have been on a disciplinary hearing or you really feel you cannot return. Maybe you've been sick for a long time and you really feel like you need some extra help and support. Your work maybe wants you to go on temporary disability and they're not quite sure what is going on. So they would send you for a functional capacity assessment to an occupational therapist. Okay. So the goals would normally be either for rehabilitation or readiness to kind of get back to work, to get a safe return. What is your work status? Are you able to work? Are you able to concentrate? Like Prof said, there is so much cognitive influence in this as well. Also to determine if you have a disability status too. So would it be a permanent, a temporary disability status? But then also your capacity. So even though I have a permanent disability, I'm not incapable of work. So it's a fine line and a tricky judgment to be able to do those two. But most importantly, it's can you meet the basic requirements, the essential components of your work? Okay, so if an insurance company sends you to the occupational therapist, you're not likely to see the end result of this work. They will normally say, yes, we are going to put you on temporary, or no, we're going to put you on permanent. This is what we're going to do. If you're sent by your doctor, so for example, Prof might refer somebody for assistance and help to the OT, then you would probably have a sit-down meeting with the OT afterwards to be able to discuss your results and see what you need to be able to do. Okay. With the insurances, there is two types of assessments as well. So you might be assessed for one for your own job. So for example, you may be a secretary. You'd be essentially assessed for the specific components of being a secretary. However, there is also a disability component or an insurance component called for any job. So that would be specifically then assessed, could you do anything? So just check with your brokers what you have as well before you're going in there, because while you may not be able to do your own high capacity job, you may be able to do a lower level functioning job, and that would influence, for example, your payout. I must just say that OT is at the heart of things. We want to keep people at work. We want to keep people functioning. We really believe that there is so much value in having a purpose, even if it is only voluntary, and also having a life that you have with living, a life that you feel functional. So maybe it won't be getting you back to work, but it'd be able to help you with your performance components, those things like concentration and memory, to be able to really live your life to the fullest. So the process would normally be, because I get a lot of questions about this, what is going to happen to me? Am I going to be able to survive? An OT would normally obviously call you, contacted you, and then book you out for a day assessment. It would be quite an in-depth interview. So note to self, try and be as honest as you can be. Don't feel shy. Really share how myasthenia affects you, because we know that's why it's called the snowflake disease. It affects everybody in their own unique way. And describe everything as it would be your worst day. So on your worst day, how does it impact you getting up and doing your hair in the morning? How does it impact you getting dressed, caring for your children? How does it impact your sleep? And then also the frequency of the days like you have as your worst days. A good OT will guide you in these things too. They will then ask you probably to fill out a whole lot of questionnaires. So remember your glasses, such as questionnaires such as the DASH or the PGAP or the HADS, which are really more based on psychosocial motivation, how much sleep are you getting, and it's more of a self-report. So it's, I feel like this is happening. Why this is an important component as well is it really shows, are you willing to get back to work, or is this well, I'm sick now, I can't do anything? And they'll also then obviously administer some standardized assessments looking at your cognitive functioning, such as the CAM or the R bands or a MOCA, your physical functioning. So yes, wear your tackies. They're going to make you walk, they're going to make you lift, they're going to make you carry, they're going to make you squeeze, grip strength, depending obviously on the components of your work. So if you are a bricklayer, I'm probably going to try and see how much is MG affecting you to be able to lift and carry and bend and stoop. However, if you are sitting behind a computer all day, I'm probably rather going to test your typing speed. Observations obviously come in really, really strongly here too. So while you are busy, an OT will ask, for example, do you have pain? Do you need to adjust in your seat? Do you need to do those kind of things? And these will also form part of your report. And then very importantly, a good OT would also do quite a bit of collateral. So they will ask for doctor's reports. They will ask for a number to contact somebody at your work to see on the job, how are you doing? How are you coping? And they'll also ask for somebody at home to see those basic functions at home. What are you doing? How are you coping? And how much assistance do you need? Okay. So things to note, ask for a break if you need one. It's not going to count negatively against you. Please ask for a break if you do need one. If you're struggling with your memory before you're going into the assessment, write a list of your doctors, bring the names of your medications, write when you had your hospital admissions. I know for me, I've got a file that I take with to every new consultation. If you don't understand an instruction, ask for repetition or clarification. Bring your Meston on, don't forget it. And then importantly, get somebody to drive you to the assessment and home from the assessment, because they need to see within this maybe 2-3 hours physical workspace, could you be able to comply with these physical demands for a whole day? Probably going to push you, which sounds terrible, but you need to be able to see, are you going to cope? So get somebody to be able to drive you home. As we know, once our muscle energy, once that's gone, it's gone. Okay. And very importantly, a lot of us suffer from the post-fatigue kind of feeling of burnout. So once you're home, once you rested, maybe you try and sleep that night, and then you wake up the next day, phone the OT and say, this is how I'm feeling now. A lot of times we feel okay, we push through. I know I do a lot of times, especially with my little one. And then what happens is the next day I feel completely exhausted because, you know, we're completely wiped out. And just this knowledge of how does this affect you the next day, if you have done this, what it would be is very important. So OT would then obviously compile all of these things, put everything into a nice report. As I said, sometimes you would see the report, sometimes not. A lot of times when you do have that feedback, it is really to be able to see what reasonable accommodations can be put in place to keep you at work. So first prize for insurance companies is not to board you, but to how can we change, adapt things to keep you at work. And this is obviously very set in legislation. If we look at the white papers on disability as well as our lovely legislation, we really do have things to back us that we can have reasonable accommodations. Obviously, it has to be reasonable. So you can't go and ask them to restructure, rebuild an entire company around you, but there are always little nuances that you can do to see, can you cope. So very typically, after the report, the OT will suggest some things. You may be able to then look at a 3-month trial period. Can these be implemented? What can happen? Then a little bit of maybe job coaching, a little bit of case management. After this, a reassessment. And if you're still not coping at that point, what is going to be happening? If you can cope, can we then keep on doing these reasonable accommodations, or how can we change it? So reasonable accommodations could be anything from restructuring your workspace, making sure you've got the correct ergonomics thing, how you're sitting, how you're holding yourself, what you're doing. Do you have to walk up and down 100 times? Could that be automated? Flexible work hours, maybe avoiding the traffic. I think due to COVID, learned a whole lot more about being online and doing working things. It can be something as simple as getting a parking space close to your work. It could be getting a ramp installed, or if you're struggling really at the bottom to get on and off of the loop, having a grab rail. And then specifically for the person themselves, so not the company to implement, but yourself, would be something like energy conservation skills. And these would be able to be given to you from either the psychologist or the occupational therapist, as well as stress reduction skills. So DBT, CBT are both great options to be able to learn some skills on how to manage yourself, what to do, how to implement different changes in your life to be able to do what you need to do. If you're wanting to look more into some of these reasonable accommodations, there's a great resource called the Job Accommodation Network, which can give you some free ideas and tips. And you can take these to your employees even now and say, can we try out a couple of these so that I don't end up having to go down this route? Yeah, I spoke quite fast and I did quite a lot. So I think let's check if there are any questions. And yeah.
Yeah, I would just, from my side, Candice, very, very interesting. I would like to say to anyone there that's obviously I'm sure you'd all know that we have someone with MG working in our office, and that open communication is absolutely critical. I know it's probably terrifying, and I realize that not all bosses are as equally as understanding and accommodating, and personalities are different. But just as an example, when we moved offices, we were planning like a chill area, like an informal discussion area, and we thought that getting beanbags would be a great idea. And Megan turned around and she said, like, guys, I love you all, but I'm not going to be able to get off the beanbag. And it was something that we had never even thought of. We in the day-to-day functionality, we don't understand. And had she not been honest and just said, like, immediately off the bat, I'm never going to get off the beanbag, so it's not going to work for me particularly. We knew immediately then that was not going to be a functional idea, because we never wanted to exclude a member of the team. And as a result, we went to something else. So I know that it is often very difficult, and it makes you vulnerable to some extent to have to really share the raw vulnerability that you have as a patient with an outsider, someone who you might not be personally close with. But just an encouragement to all patients that, sometimes you'll be surprised at what can be done. We've also got a couch in our office, and I'm scared to say that Megs hasn't used it the most. The rest of us use it more. But you know, when we moved, we thought, well, what can we do to make her work day a little bit more comfortable if she's having an off day? And that was one thing that we knew would be able to give her, you know, an immediate place to rest. So yeah, I just wanted to throw that out there. I'm not sure if there's any direct questions for Candace. Here's someone.
Yeah.
Can this assessment be done before you start working? I'm 23 in my final year of environmental science and worried about being able to keep up with a 9-to-5 job in my current state.
Yeah, so it can definitely be done prior to getting a job. It wouldn't be a requirement of the job. So the way our disability legislation is based, they wouldn't be able to say, well, we can't employ you because you have a disability, but it might be a great way for you to understand what do you need, what can you do. So for example, I only work a half day. I only work certain hours. I have flexi hours so that I can do more intensive work and then more relaxed work. So it might be nice to do it by yourself. I know there's some great VOC OTs at all of the major universities. So yeah, to even ask them, would you be willing to assess me, give me reasonable accommodations, and help me structure around what can I do, so that when you go to your employer, you can say, super, I do need these reasonable accommodations, and then how can we work together to implement them? Like Katie said, sometimes it's very daunting. So also having somebody on your side, like your case manager or your occupational therapist or your psychologist, is one of those things to be able to just help advocate for you. And I know Rare Diseases does a lot of that too. Megan and I are class moms kind of for the rare disease support group. So it's great to be able to have that opportunity to advocate and help people advocate for what they do need.
Thanks very much, Candace. Very, very interesting. Okay, so we're going to move on to our last speaker of the day, Barry Shangwenyana. Barry is a BSc Medical Science and he's done a BSc Genetic Counseling. He's an intern in the Division of Human Genetics. He's completed his master's degree with a year which focused on assessing, sorry, I've just lost my screen, patient recall, and understanding and genetic vocabulary of genetic concepts in the South African setting. In his role as intern, Barry provides genetic counseling to state patients and is involved in teaching and research. Barry, before you start, I want to ask a quick question. I'm just launching a poll to the audience. I'm going to give you guys a minute to answer these questions. After listening to Prof's talk, I wanted to know this. How many patients have used rituximab? And how many patients have been checked for sleep disturbances? And I think at the end of Barry's talk, I'll probably ask you how many of you have actually received genetic counseling, because it's always quite interesting. So Barry, if you don't mind, I'm just going to give them another 30 seconds to answer this poll so that we can get these answers. Okay, 20 more seconds. And there we go. 5, 4, 3, 2, and 1. Thanks very much. Quite interesting. Only 79% of patients have not used rituximab. Obviously, as Prof was saying, it's not necessarily first choice, but it was quite interesting for me. And how many patients have been checked for sleep disturbances? 66% have not been checked. So I think if you're waking up with that chronic fatigue all the time, maybe something, and you don't sleep well, maybe something to consider getting checked. Okay, cool. Barry, sorry, over to you.
Okay, thank you for the introduction. So we've heard a lot about MG today, and yeah, I'm going to continue on that. So my role today is to talk to you about multifactorial inheritance and myasthenia gravis. So with myasthenia gravis, it was first described in 1672 by Thomas Willis, and it is defined as a chronic autoimmune neuromuscular disease that is characterized by weakness of the skeletal muscles. So the skeletal muscles are involved in breathing, swallowing, facial expression, eye movement, as well as locomotion. So these symptoms, they tend to worsen after long periods of activity, but then they do improve after longer periods of rest. So in someone that has got myasthenia gravis, the ocular muscles are involved, and that results in double vision in that individual, drooling of the eyelids. And because also the facial and the throat muscles are involved, we've got the patient may present with difficulty in speaking, difficulty swallowing, and limited facial expression. So there's also weakness in arms, hands, fingers, legs, as well as the neck, because the neck and the limb muscles are involved. And in some instances, you've got the chest muscles that are also weak, and that may result in a respiratory failure. So the way in which myasthenia gravis is caused is that there's an error in the transmission of nerve impulses to the muscles. And as Prof has mentioned, I will also just explain again, just to recap. Sorry about that. So normally what would happen is that you would have a nerve impulse that travels down the motor neuron, and then when it reaches the bottom of the motor neuron that's from the brain, there are chemicals that are released, or what we call neurotransmitters that are released, and then these neurotransmitters, to be specific in this condition, myasthenia gravis, the neurotransmitters are called acetylcholine, and then these acetylcholine are released, and then what they do, they attach to the acetylcholine receptors that you find on the membrane of the muscle, and that then carries the nerve impulse into the muscle, and then it causes the muscle to contract, and then there's movement. So, but what happens in myasthenia gravis, there are antibodies that are formed by the body, and then what they do, they attack the acetylcholine, receptors, and then as a result, they destruct them, and then they degrade them, and then we've got a few of those that are left. So now what happens, the message will still be carried down, the neuron, but then the neurotransmitters are not able to bind to the receptors. Therefore, muscle contraction is prevented. There's also the thymus that Prof also mentioned, that we also know that it may also play a role in the condition. So what the thymus does in the body, it's sort of like a site of immune function. So what it does, it sort of like sends incorrect instructions to the developing immune cells to form antibodies that also attack the acetylcholine receptors. So both males and females are equally affected, but we know that women under the age of 40 years are the ones that are mostly affected, and also males that are over the age of 60 years. But this condition may also occur during childhood. So most often it will occur in an individual that has no family history. That is to say, you don't have an individual, you don't have other relatives in the family that have been affected with the condition. So about 3 to 5 individuals with myasthenia gravis, they have got another affected family member. So myasthenia gravis is thought to occur due to a combination of environmental, lifestyle, and genetic factors, but the genetic contribution is not well understood. So many factors, they influence the development of the disease, and this is called multifactorial inheritance. So what is multifactorial inheritance? A multifactorial inheritance means that there are many factors that are involved in causing the disease manifestation. So you've got the genetic factors that are involved, environmental, as well as lifestyle factors. So this combination of genes each have a small like risk, and then it adds up. They all add up together, and then in addition to the environmental factors, and then they combine and then to cause the disease manifestation. So in certain conditions such as albinism, the genetic factors predominate, while you've got other conditions where the environmental factors are the ones that are predominating. So we have got some of the, as I said, some of the conditions are purely genetic, as you can see on your left and on the left side of the screen. So the ones that are purely genetic, they are rare, and then the genetics that is involved there, it's simple. And then these ones, it's easy for us to test for the genetic mutation or the genetic fault, and then there's usually a high recurrence risk. And then on the right, we have got the conditions that are purely environmental. So these ones are common, and the genetics that is involved is complex, We don't have genetic testing for those ones, and there's usually a low recurrence risk. And then myasthenia gravis would sit in the middle, which is a combination of the genetic factors and the environmental factors. So characteristics of multifactorial inheritance. So the diseases that have got a multifactorial inheritance pattern, they occur more frequently in one gender than the other, but they are not limited to sex. As you've seen, like with the myasthenia gravis, both sexes or genders are equally affected, but things like your cleft lip, which is also a multifactorial condition, which it usually sometimes like it occurs mostly in males compared to females. So again, we know that the concordance rates in monozygotic twins contradicts the expected rates according to the Mendelian laws. The disease frequency also tends to change with ethnicity, and disease can occur again in isolation. So the multifactorial inheritance disease, they tend to run in families, and that's because the affected individuals, they've got relatives, and then with their relatives, they share the genes with them, and they often share similar environments. So parents with multiple affected children are more likely to have a genetic contribution to the disease. So family history in this case is important. So if there's a family history, there's a higher chance of recurrence. So does the recurrence risk increase with increasing number of previously affected children in the family? So our role as genetic counselors in multifactorial condition is that we meet with the families that are with the history of the condition, and then to discuss with them the risk of recurrence and occurrence based on the family history that they would have given to us, and then also discuss appropriate medical management and care of the condition. We also facilitate appropriate referrals to other allied healthcare professionals, such as the OTs that Candice spoke about. We also discuss limitations, potential benefits, disadvantages, as well as the appropriateness of genetic testing. And also we discuss preventative measures. So if you want to know more about multifactorial inheritance and other conditions, so you can contact us. So we are based at the National Health Laboratory Service in Braamfontein, Johannesburg. And then we run our genetic clinics in state and as well in private. So in the state system, we've got our genetics clinic located at Charlotte Mateke, Johannesburg Academic Hospital, and Chris Hani, Baragwana, and Raima Musa, and Vest Donald Gordon Medical Center. That's where our private clinics are. And then I've also included our telephone numbers and our Instagram page, as well as the email address. So if you're from Johannesburg, you are welcome to, you can contact us and then we can arrange to meet up with you. And then if you are from outside Johannesburg, what you can do also, just contact us and then we can try to arrange maybe a telephone consultation, or if there's a genetic counselor near you, and then we can also facilitate that. Thank you.
Thanks so much, Barry. So interesting. I am indeed going to ask the question. I'm launching another poll, and I'll give everyone a minute to answer with regards to genetic counseling, but also just a reminder to our patients that if you are wanting to receive genetic counseling or even just generalized counseling, you can always get in touch with our office. We do have a long-standing relationship with the genetic nurse from the NHLS, and we are in touch with all the genetic counseling centers across the country, and we'll be happy to refer you and help facilitate making sure that patients actually get genetic counseling. I know that many people don't even understand what genetic counseling is, or have never been offered genetic counseling, and for me that's a real shame, because it is absolutely so helpful and invaluable in terms of just understanding your condition, family planning, etc., etc. So very, very, guys, another to vote. I'm going to close the polling now.
Do you think it's for
think we might have lost Kelly. Anyway, just thank you so much, Barry, for chatting and all of that. I think that they are going to look at the poll and then get back to us. Just see, are there any questions for Barry? Are there any things that anyone would like to ask? See, there's a question from Sharon. Since MG has a multifactorial inheritance, who should have the genetic testing done?
Okay, thank you for that, for the question. As I've mentioned in the presentation, it's a multifactorial, with multifactorial conditions, we do not have genetic testing for those ones. So yes, we know that there's a genetic contribution to the development of the disease, but unfortunately, we don't know the specific, it's not like the purely genetic ones where you know there's a specific gene that is involved and then you can test for that. So we don't have any, unfortunately, we don't have any testing for MG.
Yeah, I know personally, I actually did the testing before we looked at falling pregnant, just to kind of put myself in the space. Would it be possible? What could I do? So I do think that being able to access something like this is a great way to put your mind at ease if you are thinking of starting a family. So thank you so much, Barry. Thank you for your resources and sharing with our MG community.
Thanks, Shane. Thanks so much for stepping in there. Yeah, Kelly is battling a bit with her internet. So just to get back to everybody on the polling, the question, have you ever had genetic counselling? Only 9% of people said yes, and 91% said no. And then, did you know what genetic counselling was prior to this discussion? We've got 61% saying yes and 39% saying no. So yeah, very, very interesting results. I'm not sure if we're going to get Kelly back in time. But yeah, just to end off, yeah, thank you so much to all of our speakers for joining us today. Oh, there, we've got Kelly coming back on again.
I'm now on my phone because, as luck would have it, the internet's just dropped and everything's gone dead. So I don't know, Nix, I'm sure you thanked everyone. Just a big thank you to our speakers. Thank you so much to Mylan for sponsoring today. Much appreciated. There was a burning question from Helen. I'm not sure if Prof and them are still online. Please excuse the background noise. My kids are now going mental because they've got nothing to watch. Question, is there an idea of how many MG patients we have in South Africa? I'm not sure if either Prof or Barry could answer that.
So we've done two incident studies. The one was published in about 2016, and the other one was published in about 10 years prior to that. With both of those, we used antibody positive tests. So that would cover about 95% of patients. And we found that our incidence rate over a 2-year period was very similar to the rest of the world. So we have a very similar kind of incidence of acetylcholine receptor antibody positive patients. We have a slightly higher incidence of MuSK. We did a follow-on study on MuSK patients, which we did with Oxford. It's interesting because it was a slightly higher than Europe, but similar to African Americans. So there's definitely MuSK MG appears to be slightly more prominent in our patients with African genetic ancestry, but it is still a very, very low percentage. Those patients are going to be more patients with what we call ocular bulbar MG. So they have a lot of, the myasthenia is very much concentrated around swallowing and breathing. Yes, that's the short answer.
So, Prof, I just see there is a question about that you mentioned about incidence but not prevalence.
So the prevalence, we haven't got good prevalence data. It's going to be difficult because it's, there is a small proportion of patients that have not got antibodies that have got so it's going to be a difficult exercise to do an epidemiological study properly. Of course, what is also important is that a lot of our patients that do not have access to specialists might not even know that they have got myasthenia, and are not treated. But I don't expect that the overall prevalence of myasthenia is different in our country or in Africa to anywhere else in the world. There are some differences, and despite what I've said about MuskMG, which I think has got slightly more African flavor, there is we're doing a lot of research on eye muscle involvement, because I think that there is so as Barry said, it's a multifactorial or a complex disease. It has different kinds of genetic components, very, very small, a lot of different genes with small effect sizes. But we seem to see that amongst younger people, particularly with African genetic ancestry, that there is a propensity to develop eye muscle involvement, which is resistant to treatment. So we're actually doing a lot of research on that, and we're putting in a grant now to the Myasthenia Gravis Foundation of America to develop biomarkers for that particular problem. So maybe in a couple of years, hopefully if we're successful, we will be able to share those results with you guys. But I think I saw there was quite a few questions about, do people have to go for genetic testing, etc. In my view as a clinician, no. There is no genetic, this is an academic research tool to try and understand the underlying story of myasthenia. That's why we look at different components and different genes that could be contributing to the disease pathogenesis. But this is not something that you go and do a panel for. So to answer that question simply, no, there is no genetic test to go and do, and you don't have to go and let your children be tested for anything.
Thank you very much. Well, Prof, Barry, as well as Candice, thank you so much for joining us today. Honestly, a fantastic webinar. I think such a great opportunity to be able to enlighten patients, bring them together, you know, understand the challenges, etc., from their perspective as well. So really appreciate your time this morning. I hope all of you that are out there working on the front lines get some rest over this weekend and that you stay safe. To all of our patients, I hope you guys have had a fantastic MG Awareness Month. I hope we've, you know, managed to create some awareness through this webinar. Thank you again to our sponsor, Mylan, for giving us the opportunity to do this. And yeah, I hope you guys all have a fantastic week going forward. Thanks again so much. And if there are any further questions, please do pop them to us and we will try have them answered. And we will make this recording available on YouTube. We will publish it to our channel so that it is available for any patients who might not have been able to join us this morning. So thanks so much. Sorry about the IT issues. Hoping that we get some rest. I think it's much needed. Apparently my internet's taken the weekend off. And yeah, just a fantastic webinar. Thanks again. Bye, everyone. Cheers.
Bye.